imagine will have come across the Beecham ethical principles. This is familiar to you all, is it? And so what I've done is put together some cases, some very simple sort of statements where there is some ethical issues to be thought about. And what I'd like you to do in your groups is to think of an example of this situation, think about what are the issues, and then see whether or not applying the ethical principles helps with sort of decision making. And most of them there isn't a right answer, but they're things that we have to deal with relatively frequently, so probably we think about them relatively frequently. You may or may not have come across them, you may or may not come across them frequently. Some of them you certainly will have. But I think it's also useful to have other colleagues, hearing how they address things. We've been doing a workshop at the Royal Bournemouth Hospital for consultants about allow natural death or the DNA CPR decision making, and actually getting them to talk to each other about how they have the conversation with the patients. And it's been really very interesting to have a whole group of different consultants from different specialties to see how they tackle this particular problem. And it's been, we've learned from it, and I think they've all found it helpful to hear how other people start the conversations. So, can I throw this open to everybody? The issue that when you've got a patient who says, I don't want to know the details, thank you very much. What are the problems that we come across in this situation? Obviously, everything we're talking about, we are largely talking about people who are approaching the end of life. We're talking about palliative care type patients. But what sort of issues does this throw up?
It makes it very difficult to advance care plan them because, you could advance care plan them without giving them specific facts about their actual illness and just find out what the priorities for them are, because I'm assuming that they know that they're dying from this illness.
And that's an assumption, isn't it? Because there are some patients who just don't know, don't want to know anything at all.
No. But you need to explore with them what they do know, what they understand about their illness. You may have to give them some information about it, because otherwise you're going to get things wrong for them, aren't you? Yeah. But you could talk about it in general terms, respecting their autonomy. We're using our ethical principles, but trying to find out, even if it's just basics, where do you want to be at the end? So you can do that without giving them too many details.
So anybody else, any thoughts, comments?
I wonder if this is a function of relationship as well, because as this evolves over time, somebody may have information right at the beginning of their illness, for example, that the disease is incurable. And along that timeline, as your relationship with them develops, either in primary care or whichever setting you're in, things open up and you're able to break down those sort of denial bits and the collusion bits. It isn't a single point in time, and I suspect it evolves over time into those conversations. Yeah. If you were to become poorly, where would you like us to?
Yeah. So there is an issue about how to do advanced care planning, isn't there? But if you've got someone who, we find sometimes people say, I just want to take each day as it comes. I don't want to know all the details. And that can mean that actually having optimal care suffers, can't it? So it's not just advanced care planning, it's actually trying to ensure that things don't happen to them that shouldn't happen to them. And there's how do you address that? And yes, if you have an ongoing relationship with somebody, that's a possibility. But has anybody else got any comments about continuity? Are you finding you're able to have continuity these days? What is your experience in primary care? Because, I'm interested in Lavina.
I had a patient. I think we're sort of in the same scenario where actually she was happy to talk about her illness but didn't want to talk about the fact that she was dying. So she was happy to talk about the fact that she knew her ovarian cancer was currently causing bowel obstruction, but that's as far as she wanted to go. So she actually ended up in Forest Home, and what was nice, you asked about continuity and whether we can, and general practice is changing and the pressures are on, but it was nice to be part of looking after her there and still see her and discuss with the consultants. And actually, I suppose some people would say that in a way she died in denial. That might be how we describe it, but it didn't do her any harm. That was how she wanted exactly what you said, take one day at a time, and she could see herself getting worse, and we didn't need to.
So did you have any conversations about other people being allowed to have information, or about other people being allowed to make decisions for her, or anything like that?
Yeah, I think we had, and in fact Dr. Anna at Forest Home, I think, had spoken to her, and you know, if she had become more unwell, so it had been discussed. Had she become more unwell, she was happy for her husband to speak on her behalf. So that had kind of, but again, had been talked about. If you become unwell such that we can't ask you, but it didn't. We weren't saying when you become so unwell that you are nearly dying. Again, the word dying just never came up, and we just talked about possible progression. And she answered all the right questions without anyone having to actually use the phrase she didn't want used or get to the bit she didn't want to get to.
But there are some patients who don't want to know the results of their tests, aren't there? Have you had this experience? People saying, I don't want to know my CT result. And actually that can be very difficult, because you then may have decisions to be made on the basis of the result of the CT scan. And I've certainly had people in a ward round who say, you know, do you want to know the result of your scan? Not if it's bad news. So it's a real...
It's good. Isn't one of the things is, whilst respecting their autonomy and trying to work, is also to explain to them what the difficulty is for the people around them, and actually to say, you know, we want to care for you, and actually in order to do that there is a degree to which we've got to have some conversation, otherwise we can't. It's not just a responsibility for looking after them, they have a responsibility to allow people to care for them.
And I think
actually
that's
explaining what might need to happen in terms of communication from our point of view.
Has anybody else got any thoughts on it?
It's a big burden for the relations if they feel that the patient doesn't know, and that it's all down to them practically.
Yes, and that's something else that might be worth exploring with the patient of, you know, this is very difficult for your relative. So there is, I mean, you know, here am I coming up with what I tend to do, but in those circumstances I would tend to say, okay, I respect what you're saying. My experience is that quite often as time goes on, like Paul said, eventually they get a bit more confidence that we're not going to frighten them or whatever. But I would want to say there may be a situation where we do need to involve you, and you know, I need to be able to do that. And equally I may say, is there a family member who you trust enough to make decisions, and can we involve them in decisions looking after, you know, on your behalf? It doesn't happen very often, but I've certainly had a few where actually, fortunately, we haven't had to make any big decisions, because it's been purely a palliative approach. We haven't had to decide about chemotherapy or radiotherapy or, you know, something, a significant treatment that someone would have to consent to. But it is very difficult. So much in medicine, and particularly in general practice, is involving the patient in the choice making. You know, how much have we lost by our stopping being paternalistic to patients when we know far better than they do what might happen to them? And I think that's quite an interesting thing to think about. Has anybody got any thoughts or comments about that?
I think they still value us as our opinion, don't they? Do you know what I mean? There's still a way of helping them along the way to making their own decision, a sort of middle ground between telling them what to do and making a decision for them.
I agree with that.
And I think that's, in most cases, there's always sticky ones, but I think that's the best way to go about it. But it varies enormously, doesn't it, how much some of them want you almost to make the best decision for them, what you think is best, and how much some of them want more information.
So do you think most GPs would be happy to, confident to, you know, actually steer people? Is that, you know, I'm just interested. I'm looking for feedback. What do you think?
I think we probably all have different
opinions. Fishing patients, really.
So who does fishing?
The patients.
Patients,
yeah. So they're kind of looking very much towards me and the oncologist for a guide, I would say, more than a... Yes, so in some ways a slight steer, and they do find that very difficult sometimes to make their own decisions. For example, I had recently a woman with a tricky endometrial cancer, very likely to recur, and she just couldn't make up her mind whether she should have chemotherapy or not. And it was always, well, what would you do, Hilary? What would you do? And I said, but I can't make that decision for you. And we tried to whittle it down to statistics so that she could try and make some assessment of it, which I don't think helped her at all.
Out of interest, did you have a clear view about what you felt was the right thing for her to do?
Yes, I felt, knowing the type of cancer that she had, which was an aggressive cell type, that she should have the chemotherapy.
So she should have it?
Yes.
Right.
and I felt I had to sit on my hands quite carefully not to state that, although whether I'd have chemotherapy or not is completely not the
But wouldn't an
matter.
oncologist say to her, I recommend that you have the treatment?
I tried to say to her, how would she feel? She had to, in terms of making that decision, how would she feel if the cancer came back and she had opted not to have the chemotherapy?
Was this potentially curative though, or was it palliative chemotherapy?
She's sitting in a horrible situation, a very aggressive cell type, which I've seen before, and I think potentially her cancer will come back regardless at some point. And that's what makes that very difficult, because I can see that it will buy her time. Otherwise, I felt that it would probably leap away, and I'm not sure I felt she could cope with that either. But I think she is sitting in a horrible situation that cancer will recur regardless. So, you know, you're asking somebody to go through some pretty nasty treatment, and one thing that was really important to her was hair loss, which obviously she was going to have, for potentially no gain.
Limited benefit.
And the statistics were low. We did give them to her, and interestingly, the oncologist said, well, I think 5% is enough for us to recommend chemotherapy. And I thought,
Are there any thoughts or comments on that from primary care?
What sort of time do we think we were going to possibly buy her? Do you see what I mean? Yes.
I think probably as soon as she'd finished her 18 weeks of treatment, that cancer would recur within 3 to 4 months.
And then there would be unlikely to be any real active.
Potentially give her another cycle of chemotherapy, but half as effective again.
And without it?
Without it, with that type of cell type, I'd say her cancer, she probably could enjoy sort of 6 months.
So that's the difference.
It is, yeah. That's what you
Quality over quantity
Yeah,
again.
and I felt
6 months with hair.
Yes,
Yeah.
you see, and I felt giving her a 5% statistic for somebody who doesn't know anything really about cancer and benefits and risks, and I don't think that really meant anything to her. And actually what was really, really important was, as you say, 6 months with hair or 12 months mostly without hair.
Mostly feeling
and
awful.
feeling crap.
Yeah.
There is and I hear what you're saying, what everyone's saying. There is the quality, quantity sort of way we think about end-of-life care, isn't there?
But we don't discuss that very often.
No, but we often think that not having chemotherapy will allow you to have a quality time, and actually that isn't necessarily the case. Not having an intervention equals a quality time.
Yeah.
Again, it isn't necessarily the case. And I find in palliative medicine, people will say, let's focus on quality. That's when people are trying to sell stopping chemotherapy to the patient and selling them palliative care. And actually I'm thinking, crikey, I'm not offering you quality. I'm hoping I can control your symptoms to make your life a bit more bearable, and you go to hospital less often. But
that's
it's not
the patient's priority.
Yes.
What are their priorities for their remaining time?
Yes.
And that's where helps you to guide them to
Yes.
the right thing. So
Yeah.
if their priority is having their hair and having theoretically a better quality of life, then that's the non-chemo route. Whereas if they want every chance to live as long as possible, then it's the chemo route, isn't it? And it just, every patient's wishes are different.
I think you're right. It's about actually assessing what does quality mean to that person, really. Tonight's presentation was excellent again. They're superb masterclasses. I think because this one was particularly focused on ethical considerations, and we had a lot of dialoguing over case studies, it was particularly helpful for us to reflect on some very difficult problems around end-of-life care. One point that stood out to me was around the facilitation of resuscitation and do not resuscitate orders, and perhaps we need to be moving more towards discussing with patients coming to a natural death, rather than considering that perhaps even at the point of coming to death, that resuscitation infers an active treatment as opposed to something that is natural and should be facilitated.
We had some really interesting discussion around end-of-life ethical issues, and it was very useful looking at the 4 basic principles of ethics to take a lot of our thinking back to, and also particularly with DNAR discussions, thinking about selling it more to patients, talking about allowing a natural death was quite a useful practical point.